and it was a great privilege to come back here and talk. Can you hear me? Good. So when Julie asked me to speak about what do you talk about in diabetics and coronary artery disease, I thought, what should I say? So I put a very provocative title for Leave Nothing Behind. Do you understand what that means? Or any idea? Okay, so let's see, that's a good basis. So this is very little data here. I will be speaking mainly on my experience and what we look after in a patient when they present with diabetes and coronary artery disease. By the way, these days, diabetes is considered to be an extension of coronary artery disease. It's equivalent to a person who is already having angina or a previous heart attack. So, I thought I will talk about a little bit about the pathophysiology, something about the treatment options, medication optimization, percutaneous revascularization, surgery, and what next to come. But then I started thinking, I am coming to a field where all the experts in diabetics are sitting here. So why should I talk about how do you treat diabetes? So I'm not going to talk anything about medicines or how do you maintain a normal glycemia. I'm not going to talk about it. And I'm not a surgeon, so I will be speaking more about what I specialize. Okay, it is one of the leading causes of mortality among patients with diabetes mellitus, and in fact, almost 60% of mortality could be attributable to diabetes, coronary artery disease in patients with diabetes mellitus. So, we all know that deranged carbohydrate metabolism is seen in about 40 to 50%. Times you get patients diagnosed for the first time with diabetes when they are coming into the hospital. Now, we also know that diabetes is a multi-system disease. It causes endothelial dysfunction and especially persistent of hyperglycemia, glycation end products, as well as the oxidative stress that damages the endothelial function. Now, once the endothelium is damaged, which actually accelerates the atherosclerosis rather than protecting the vessel wall. Now, with the endothelial dysfunction, what we are actually talking about a reduced sensitivity of the vessel wall to the nitric oxide as well as a decrease in production of nitric oxide. Now, together with that, there is a hyperreactivity of the platelets. That means the platelets become more sticky and there is a thrombogenic environment or a milieu already. So that means the platelets will aggregate and they will occlude the vessel, and that's why you do get quite a bit of myocardial infarction. And after you treat, there is also accelerated proliferation of the smooth muscle cells as well as more matrix deposition, and that in turn will increase the chance for instant restenosis and other problems. So what do we see in clinical cases? You see a higher incidence of stent thrombosis, myocardial infarction and death. In addition, when you see an angiogram with a patient with the coronary artery disease, one of the characteristics we see is actually the arteries are much smaller in caliber and they have a long diffuse segment of disease. Now, with somebody with a very localized disease, it's much easier for us to treat. But with a long diffuse disease, we often think, what's the best way to treat this patient? And we end up producing a long segment of stents, which in itself is another factor promoting both instant restenosis as well as myocardial infarction. Now, this is one of the studies. So the Swedish people are very good in following up patients with heart disease. They have a national registry which keeps all the data for many years, more than 30 years of data, very well documented. So what I am trying to show here is, in Swedish patients, when we followed the patients with diabetes and without diabetes, actually the proportion of patients who are dying following a myocardial infarction is much higher in diabetic patients, and that persists even after all the advances in treatment. Now, these pictures are drawn by my daughter. This is just a schematic representation. So that's a road okay, you see any road with a house there, some greenery there and plenty of plants there. And if you look at any of the, imagine this is a coronary artery, you do see a little bit of say encroachment or bumps on this thing. That is what we call as the plaque disease, which keeps coming. So that will be seen if you take angiogram or any of the advanced studies in any of your coronary arteries. In fact, we have seen coronary artery disease starting very early, even in people on postmortem studies, starting from the age of 20, you start seeing little bumps on the arteries. That in itself is not dangerous or cause nothing. Now, imagine a situation in which that is coming from the endothelium, some of the plaque is ruptured and it is projecting into the lumen. And if that projecting into the lumen, it's like, say, if you are going on the road, if there is a little bit of road work is happening, that's not a problem. The vehicles will go smoothly. Imagine if that road work is going on and obstructing the road, you will see a big pile up of traffic. So similar thing, if this thing projecting in is causing, say, about 70% of the lumen, that's when patients start getting a functional symptom or a angina equivalent. That means the patient is stable at rest. When they are exerting, the coronary arteries are not able to meet the myocardial oxygen demand. So the patients will start getting anginal symptoms or symptoms of ischemia. So what do? We start seeing that, okay, all right, I know there is a small disease. Okay, I will crush it or stretch it using a balloon and then put a stent there. So we say, okay, that's a localized disease. I have treated it by putting it in a stent. Okay, that will re-establish the flow and the patient will be much better at this time. So that is a good treatment as long as I thought it's all gone. Okay, maybe I am talking too much. Okay, let's move on. So we'll start thinking about the treatment options. So we have a reasonably good way of treating the disease. We are not treating the cause, but we are treating the effect of the disease by putting it in a stent. Okay, so this is one of my patients. So the patient had a previous CABG and about, say, a 77-year-old guy. He came back to me, and when we did the angiogram, he has got a significant disease in his main coronary artery. We call that disease pattern is the left main coronary artery. So the patient comes to me. So, okay, you can always talk about lifestyle modification, other things, but actually the patients want a treatment for that. So you end up treating using multiple techniques. You modify the calcium, remove the calcium, or stretch the calcium, or different things, and then you put a stent in. If you see when the vessel is empty, you can actually see the outline of the metal. So you put the stent in, and you can see, if you remember from the previous picture, the area of this area, the blood flow was quite impaired. Currently the blood flow is much better, and this patient within 1 or 2 days will definitely get a much better symptom relief. Okay, I use the word symptom relief. Please remember that is, we are only treating the symptom here. We are not treating the cause of the disease. Okay, we all say, and people even come and say, oh, I got 5 stents, but that is actually, we are only treating the way to avoid the symptoms, not the cause of the disease. Okay, now we know that in diabetic patients, you do have a diffuse coronary disease that will affect the whole length of the artery, and the vessels are already small, and also there is the ongoing accelerated atherosclerosis. So if I just put another stent in, that's not going to arrest the process. So important thing is, how do you treat the patient with the rest of the problems happening. Okay, now this is another schematic diagram. Again, I am trying to say that, okay, you are getting more and more plaque getting into the lumen, and some of them are unstable, they are ruptured. Once they are ruptured, they will accumulate platelets and other thrombogenic, it activates the thrombogenic cascade as well as the inflammatory cascade, including TNF-alpha, IL-1, IL-6, and the end result is that you get significantly impaired flow, and the patients will start getting the symptoms. So what do we have as a treatment? Okay, I had a treatment which is very useful for a localized disease. I had one stent. So I start putting all that. I put multiple stents here. So what we have actually created is we actually created a tunnel. So we know that all the functions of the greenery or the wall of the vessel, that has been replaced by a metal. So you know that as well as me, that that's not the ideal way of treating the patient. So we have been doing that for the last 20 years, putting multiple stents. Patient comes back, all right, okay, I can put one more stent, you put one stent inside, you call it a stent in stent or stent sandwich. Actually, you are cutting down more and more of the endothelium. We know that the endothelium is the living part of the vessel. Okay, so this one, I thought that I call it as the electric car story. Do you know why I put these? Which car do you prefer about these two? Sunitha wants a Tesla. Okay, so the reason I put that is, what are you seeing? That actually, when you get an electric car, most of the people who are driving, they do get a range anxiety. Or will I get breakdown or run out of the electricity within few miles? So most of the existing car makers, what they did was, they have a body of the car or board which is already being in production. They remove the electric engine and put batteries. So the range comes down. So if you look at the most of the cars around, you may get a 200 kilometers, which they promise. Actually, you get about 140 kilometers. What did Tesla do? They didn't have a pedigree in car making, but they were not currently leaders, but they were leading battery makers. So he instructed them to put, even though he's an eccentric person, he instructed them to put batteries enough to run 300 miles or approximately 500 kilometers, and then build a body on top of it. That's why those cars are better. So what I'm saying is that what we have been trying to do is the treatment which is meant for a localized disease, which is actually a different pathophysiologic process. We started using the same treatment for diabetic patients, which is definitely suboptimal. Okay. Now we know that all the different treatments, the most important thing is the medical therapy. You can use different type of medications. The commonly used beta blockers, most of you must be familiar with atenolol or bisoprolol. They actually have a vasoconstrictive property to the distal peripheral vasculature. Now we know that if there is vasoconstriction, that's not good for either your, say, insulin resistance or vasoactive properties. So that's not actually good for a diabetic patient. Now calcium channel blockers, some of them are good, some of them are not, and long-acting nitrates are actually not good for endothelial function, so it actually causes endothelial dysfunction. So if you are going to treat angina, I try not to use that. Okay. So what do we do? So in patients with an angina, or you should, if your cardiologist is treating you, you should be trying to tell them, okay, can we have one which is suited for me? We all know that medicine is not a full science. There is a lot of art, so it's always a trial and error. What is best for you is the best for you. So I'm not going to tell you that what you should be taking or what I should advise, but these are my choices. The patient is getting a lot of symptoms. I am very liberal because I don't believe in anybody suffering angina. I start telling them, you take your short-acting or sublingual nitrate as often as needed, because other than causing a headache, it doesn't have much side effects. It's a very short-acting and it's useful, and it's most beneficial at the beginning of the episode. If you wait for some time, what happens is a lot of metabolites accumulate and the nitrate spray is not going to work. Okay? Now, if you are using the beta blockers, I usually use either nebivolol or carvedilol because they have what peripheral vasodilating effects. Now, there is another drug which I commonly use called ranelacin or Ranexa, available in 375 milligram, 500 milligram. So that product is actually good, and I am not a big fan of Nicorandil, mainly because a couple of my patients had anal ulceration following Nicorandil, which was quite messy, and I selected cardiology because I didn't want to go anywhere near GI tract, so I don't use Nicorandil. Okay, ranolazine actually is quite beneficial. There are plenty of studies on ranolazine which has come a few years ago called Marisa and Carissa, which showed that it is a quite good anti-anginal. In addition, in patients with diabetics, on an average, ranolazine has been shown to reduce the HbA1c by about 0.7 to 1. So, if you continue to treat that, you will see the HbA1c will come down and that will be beneficial. Okay, I am running out of time, so I will rush through the next couple of slides. Now, the clinical events between 1 and 5 years is increased following myocardial revascularization. So what we do, we start using drug-coated balloons. The concept is you do angioplasty, you optimize the artery and deliver the drug by, say, putting the drug on top of the balloon, and you keep the balloon for about 60 to 80 minutes, 60 to 80 seconds. That will transfer the medicine. So that is a schematic diagram showing actually the drug is on top of the vessel, on top of the balloon, and that, because it's lipophilic, it's often get transferred into the arterial wall, and that reduces that neointimal proliferation. So in multivessel disease, drug-coated balloons have been shown to be better than drug-eluting stents. I'll skip that. So what do they do? Is leave nothing behind suitable for all? Obviously not. Okay, I'll stop in 1 minute. Okay. So we need to make sure we are doing them for the benefit of it. So in summary, I talked a little bit about the pathophysiology of coronary disease. We talked about the treatment options, and my message is you should be tailoring the treatment for the particular patients and do not use the treatment which is meant for localized coronary artery disease for diabetic patients. Thank you.
Thank you, Dr. Sen.